introduction. So back to the MCC objective 12.2. We're dealing with calcium abnormalities. And someone will say, oh, this is hypocalcemia, easy stuff. People really, really struggle with this. And that is why I am taking time to let us go through it. And we are going to review every single objective. So don't worry so much about that. And the rationale says that in patients with hypocalcemia, so we're going to deal with hypocalcemia first, then we'll go to hypercalcemia. In patients with hypocalcemia, tetany and or seizures may develop. So if I were you, I'll write it down, because if the objective is telling me that people can develop tetany in hypocalcemia, then one thing I want to focus on when I'm preparing for my exam is that, one of the things in a patient is the fact that they can develop, seizures. Okay, so that is one thing. They can develop seizures, particularly if the onset is acute. And don't forget that there's a lot of emphasis on acute medicine in your exam, because the MCC objective says so. Okay, severe or prolonged hypercalcemia may cause irreversible end organ damage and may be life-threatening. So we'll be going through that. So it's from the objective, that is where I'm extracting this information. Okay, so let's keep on. So given a patient with either hypocalcemia or hypercalcemia, the candidate will diagnose the cause, the severity, the complications, and will initiate an appropriate management plan. Therefore, if I were you, another thing I'll write, apart from stating that seizures can occur from hypocalcemia, is that I'll also note the causes of hypocalcemia, the causes of hypercalcemia. And then after that, I'm also going to look at what range will I say hypocalcemia and hypercalcemia is severe? What are the complications of hypocalcemia and hypercalcemia? I think we've already dealt with one, which said that seizures can occur in hypocalcemia. What is the management plan for patients? What's the management plan for patients who have hypocalcemia and hypercalcemia? So these are the things I want you to pay attention to while we are going through this. So I stated something that, look, if I'm going to break down this objective, I'm going to look at hypocalcemia and hypercalcemia from like these angles. I'll know the cause. I'm going to write down all the cause of hypocalcemia. I'm going to write down all the cause of hypercalcemia. I'm going to write down how a patient with hypocalcemia, which is severe, will present, how a patient with hypercalcemia, which is severe, will also present, the complications, and then how am I going to treat them. If I'm able to manage a patient from this angle, then that means that, look, I am already in the clear so far as this particular objective is concerned. So in other words, pay attention to hypocalcemia and hypercalcemia, all right? So doctors, are we all tracking together? This is all by way of introduction. Are we all tracking? If you are tracking together, just type yes, 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 yes. Let me know that we are all tracking together. Hypocalcemia, hypercalcemia, hypocalcemia, hypercalcemia. Okay, good. So let's start with hypocalcemia. Now, calcium and extracellular calcium, that is calcium outside the cell, is involved in various things. For example, in signaling and secretion of hormones. Okay. Number two, is also involved in muscle contraction. And number three, is also involved in the coagulation cascade. So even with the way the MCC objective was, even with the way the MCC objective was stated that I have to know the cause and the complications. If I'm dealing with a patient who has hypocalcemia, what I'm going to make sure is what are the effects of how will the muscle react if there is hypocalcemia? Will there be any bleeding abnormalities? And which hormones are affected? Dr. Tauhid, what's your question? Hello, Dr. Tauhid, what's your question? Okay, I think we'll continue. So there's a close relationship between calcium, some components so far as calcium homeostasis is concerned. Number one, serum ionized calcium itself. Number two, the parathyroid hormone, and number 3, vitamin D. So after you've written the things you're going to use to as your benchmark so far as studying is concerned, I will write hypocalcemia, hypercalcemia. What is its relationship with the parathyroid hormone, and what is its relationship with vitamin D? These are the things I want you to start paying attention to because they are very critical. Ionized calcium, parathyroid hormone levels, vitamin D. And we are going to take our time to break this all down. So I have a question, and I want you to type in your answer. I don't want you to shout the answer because at times what I've seen is that when we are replaying it, it becomes difficult for people to follow. So you are assessing a 65-year-old female in the emergency room. This patient presents with perioral numbness. The serum calcium level is 1.9. What are possible causes? This is a CDM question. Can you type them in your comment section? Don't unmute yourself because it will distract others. You have a patient. That patient presents with perioral numbness, and the level is 1.9 of calcium. What are possible causes? Just type in your answers, and there we go. Beautiful. And those who are joining us on Facebook as well, I'm also monitoring it. Dr. Jemima, Dr. Anastasia, all of you, I've seen you as well. Okay, good. So what are possible causes? What are the possible causes of hypocalcemia? Number 1, you can have a patient with hypocalcemia. Remember that I told you that, right? Like calcium levels, parathyroid, and vitamin D. You can have a patient with hypocalcemia, okay, who also has low parathyroid hormone levels. And those people, number 1 is patients who have abnormal parathyroid gland development. So their parathyroid gland was not developed well, and therefore they are not producing good parathyroid hormone levels. Number 2, also people who have normal parathyroid hormone level, parathyroid gland, but then there is altered regulation of the parathyroid hormone level itself. So these two people, so what are the causes of patients with hypocalcemia? Patients who have abnormal parathyroid gland development, patients who have altered regulation of parathyroid hormone production. Number 2, patients who have had surgery in the neck. So maybe they had a thyroid surgery and the surgeon was so aggressive like Dr. Brony that in the process of taking away the thyroid gland, he also took away the parathyroid gland as well. Number 3, you also have some autoimmune conditions. And one of those conditions is iron overload. Number 4, HIV. Doctors, please pay attention to these. Patients who have abnormal parathyroid gland development, patients who had surgery to remove, say, the thyroid gland, and in the process, the parathyroid gland was also removed. Patients who have autoimmune conditions, and an example is a condition which causes iron overload, as well as patients who have infections like HIV. Now, you remember that when we're doing the previous slide, there was something I stated. There was something I stated. That is, so one thing I also want you to write in your books is, if I have a patient who has low parathyroid hormone level plus hypocalcemia, what are my differentials? That is, patients who have abnormal parathyroid gland development, and then patients who also have post-surgical, like who have had surgery, okay? And then the autoimmune conditions and HIV patients. But then you can also have patients who have hypocalcemia, that is low calcium, but high parathyroid hormone levels. Low calcium, but high parathyroid hormone levels. And this occurs when there is response to the low calcium concentration. So then it's like the parathyroid hormone is being called into action. And you can see these in patients who have vitamin D resistance or vitamin D deficiency, and patients who also have hypomagnesemia. Doctors, this is a very technical concept, and that is why a lot of people don't get it. That is why I want to take my time so that we can break it down. And also patients who have kidney disease. And you can also see this high parathyroid hormone levels and low calcium levels in patients who present with acute pancreatitis and hyperphosphatemia. So please, in your book, write patients who present with low calcium, low parathyroid hormone. We've learned that. And now, low calcium, high parathyroid hormone levels. These are the differentials. Question, can I proceed? If I can proceed, type yes, 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 yes. Okay. If I can proceed, type yes, 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 yes. Because I don't want to rush anyone through this. Okay, good. So please make sure you are writing it down. Low parathyroid hormone, low calcium. Then low calcium, high parathyroid hormone levels. Okay. And then because we're talking about various causes, there can also be drug causes. There can be drug causes of low calcium level. And drugs which can cause low calcium levels can be bisphosphonates, calcitonin, denosumab, and don't forget an anti-seizure medication, phenytoin. Phenytoin, denosumab, calcitonin, bisphosphonate. These are drugs which can cause low calcium levels. Okay, now let's talk about the next thing. So what I want you to reflect on, and I want you to know, is that you can have patients who have low calcium levels and high parathyroid levels, and you've learned the differentials today. You can also have patients who have low calcium levels and low parathyroid hormone levels. And you should also know the relationship between low calcium and low magnesium levels. Okay, so we building on gradually. I don't want to rush anybody, as I said. Okay, good. So I want somebody to, now I need somebody to volunteer and unmute themselves and read this case for us. Or maybe let me read it and then you just put in your answer. And those on Facebook as well, please, I'll be looking out for your answers as well. Okay, I'll be looking out for your answers. And I'm going to read the question right away. So you are assessing a 65-year-old female. You are assessing a 65-year-old female in the emergency room. She presents with perioral numbness. Her calcium level is 1.9 millimole per liter. Which of the following is not likely to be noticed on examination? Hypocalcemia. Which of the following is not likely to be seen on examination? Please put in your answer. Is it A? Is it B? Is it C? Is it D? Is it E? Is it A? Is it B? Is it C? Or is it D? Please, those on Facebook, please put your answers as well. I'll be reading out your answers. So what are the answers I'm getting? Dr. Abdul says E. Dr. Juan says D. Dr. Felix says E. None of the above. Others are also saying D. ECG changes. Remember, which of the following is not likely to be noticed? And the answer is A. Which of the following is not likely to be noticed? The answer is A. Why? E is not the answer because A is an answer. So you can't say none of the above. And A is the answer, therefore F is not the answer. So you can't say all of the above. So that means that tetany can occur in patients with hypocalcemia. Tetany can occur in patients with hypocalcemia. Carpal spasm and paresthesia can also occur in patients with hypocalcemia. ECG changes can also occur. Okay, so please, what are the, features of hypocalcemia? Because if you know this, then you can be able to answer that question. A, paresthesia. B, they can have laryngospasm and they can develop stridor as a result of that. C, they can have hyperreflexia. They can also have tetany. They can also have Chivostex signs. So when you tap on their face, you see that their face is moving in a very funny way. And then they can also have Trousseau sign, where you can, as you are checking their blood pressure. So this is my blood pressure machine. As you are trying to check their blood pressure, their hand will be moving. Okay. And they can also have ECG changes. And we will come to the ECG changes of hypocalcemia. And they can present with delirium. And emotionally, they can present with emotional instability. They can present with anxiety. They can present with depression. So doctors, this is what I want you to be writing down. What are the physical exam features of hypocalcemia? Paresthesia or symptoms of hypocalcemia. Paresthesia, laryngospasm, hyperreflexia, tetany, Chivostex sign, that is when you tap on the face, okay? Positive Trousseau sign, that is when you are checking the blood pressure, the arm is moving. The arm is moving. ECG changes, delirium, emotional instability, anxiety, depression, okay? Seizures. And you note something here, I wrote something down here. Tetany is a hallmark of hypocalcemia. So if you forget all the symptoms of hypocalcemia, don't forget about tetany. Please, don't forget about tetany. If you forget about all the symptoms of hypocalcemia, don't forget about tetany. Doctors, is this clear? If it's clear, type in yes, 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 so that we can move on. Because we are taking the MCC objectives one by one, and we are building on it. Okay, good. So please, you should be able to, when they wake you up, you should be able to tell what are the symptoms and the signs of hypocalcemia. Basically, that is what this question is about. Next objective. List and interpret critical clinical findings, including differentiating hypocalcemia related to renal disease and hypocalcemia due to other causes. So if I were you, this is also another thing I'm going to write. Don't just say, I've learned hypocalcemia. The objective is saying that while you are learning hypocalcemia, you should be able to tell if you are presented with a patient, which kind of hypocalcemia is as a result of kidney disease and which hypocalcemia is as a result of other things. And how would we be able to note that? Kidney disease is the most common cause of acquired disease in renal production of vitamin D. Now, how will I be able to tell if a patient presented to me in a board exam situation has hypocalcemia as a result of kidney disease? You realize that those patients with hypocalcemia in kidney disease also present with hyperphosphatemia. If I were you, that's what I will write in my book. Hypocalcemia plus hyperphosphatemia in a board exam situation, I'm thinking about kidney disease. Simple. Doctors, let's make this thing very simple. The objective is saying you must be able to identify patients who have hypocalcemia as a result of kidney disease. And what is one thing which will help me to note that? If I see a patient with hypocalcemia, low calcium, high phosphorus levels, one of the top differential diagnoses which should come to my mind is kidney disease. Hello? Is this an eye-opener for you? Hypocalcemia, hyperphosphatemia, kidney disease. Boom, board exam. Doctors, can I proceed? Because I want to make sure this one sinks in, because this was in the objectives. I want to make sure it sinks in. Can I proceed? Okay, good. So please write in your book, hypocalcemia plus hyperphosphatemia, chronic kidney disease. So I wrote this equation for you. Break it down. Always make sure that you are breaking the concepts down. Don't just pick master the boards and read, or don't just pick Toronto notes, or don't just pick up to date and just read it like that. No, make sure you can be able to, break things down when you're asked about it. So chronic kidney disease, hypocalcemia plus hyperphosphatemia. Away, you are done. Now, next objective, he says, list and interpret clinical investigations, including ionized calcium or total calcium corrected to albumin to assess severity, and phosphate, magnesium, parathyroid, and vitamin D levels, and renal function assessment. Okay? Phosphate, magnesium, parathyroid hormone levels, vitamin D levels, and renal function assessment. So let's get into it. So you are assessing a 65-year-old female in the emergency room. She presents with perioral numbness. Her calcium level is 2.0, and the normal range for calcium for your exam purposes is 2.12 to 2.52. What is the next best laboratory investigation? You are assessing somebody with hypocalcemia. And remember that with these MCQs, in the exam, you should be able to solve an MCQ within 1 minute. So you have somebody with hypocalcemia. What is the next best investigation? That's all that the question is asking about. So some people are saying D, some are saying B, some are saying A. I'm very happy. At least the house is divided. What is the best? What if you have a patient with hypocalcemia, what is your next best step? The next best step is parathyroid hormone levels. Next best step is parathyroid hormone levels. Hypocalcemia plus hypocalcemia plus hyperphosphatemia is chronic kidney disease. That's what we are thinking. Hypocalcemia, next best investigation, parathyroid hormone levels. What do I mean by that? I've put this alarm here because the objective said you should know this. And this is from Up to Date, interestingly. It said that measurement of serum intact parathyroid hormone levels should be performed in all patients with hypocalcemia. In all patients with hypocalcemia. Then Up to Date goes on to say that it is the most valuable laboratory test for determining the etiology of hypocalcemia. Can you imagine? It is just stated black and white in Up to Date. Parathyroid hormone levels should be performed in every patient. So please, when you start practicing or when you are practicing, mock exams and the rest in preparation for your QE1, remember, always remember, hypocalcemia, next best investigation, parathyroid hormone level. It is the most valuable test for determining the etiology of hypocalcemia. Doctors, please, have I made my point clear? Please, today, by the time we are done, very, very, very easy for you. Hypocalcemia should be easy. So if you are asleep and somebody wakes you up, what is the most valuable investigation you should do in a patient with hypocalcemia? Parathyroid hormone levels. Boom. Don't even confuse it. Because, there is the vitamin D part, there's the phosphorus part, there's the magnesium part. But even before you get into all those things, always remember, parathyroid hormone level is the most important investigation for you to request in a patient. That's why I've put the alarm there. You have to know it. Okay. Further teaching point. Hypocalcemia is the most potent stimulus of parathyroid hormone secretion. So if calcium levels are low, parathyroid hormone should be secreted. Okay? As a result of that, a low or even normal serum parathyroid hormone concentration in a patient with hypocalcemia is strong evidence of hypoparathyroidism. Let's take our time and break it down. What do I mean by this? If calcium levels are low, I'm expecting parathyroid hormones should be released. So I'm expecting parathyroid hormone levels should be up when calcium levels are low. Now, if I am presented with a patient who has low calcium level, and instead of parathyroid hormone level being up, it is also down, that means that there's a problem with the parathyroid gland. Why? Because calcium levels are low, and I was expecting the gland to respond, but the gland is not responding. So another equation I want you to write in your book is hypocalcemia plus low parathyroid hormone level. The topmost diagnosis should be hypoparathyroidism. Doctors, am I clear? Am I clear? Please, let me take it again. Low calcium levels should stimulate parathyroid gland so that it will produce parathyroid hormone. So naturally, I'm expecting that anyone with low calcium, I'm expecting high parathyroid hormone levels. Please, are you following me? But if in a patient who has low calcium level, the parathyroid hormone level is also low, that means that, look, the parathyroid gland is being stimulated, but it has a problem. Therefore, I can conclude that a patient with low calcium, low parathyroid hormone levels, that patient has hypoparathyroidism. And Dr. Abraham says, bam, beautiful, because we've nailed it. So we are learning various things. Low calcium plus high phosphorus, chronic kidney disease. Low calcium plus low parathyroid hormone level, hypoparathyroidism. Doctors, can I proceed? Can I proceed? Okay, good. We are learning a lot today. Good. So I want you to memorize this. If serum parathyroid hormone level is decreased in the context of hypocalcemia, we've learned that the answer is hypoparathyroidism. If serum parathyroid hormone level is elevated in the context of low calcium, then I'm thinking about other things like acute or chronic kidney disease. And one other thing which comes with acute or chronic kidney disease is hyperphosphatemia. We've already established that. Vitamin D deficiency, and as well as pseudo hypoparathyroidism. Okay, so please memorize this very well. If I were you, I'll take a screenshot or something like that. Now, let's move on. I have another question for you. You are assessing a 65-year-old female in the emergency room. She presents with perioral numbness. Her serum calcium level is 1.9. After the initial blood work, by the way, who can type in what is the initial blood work you would do in a patient with hypocalcemia? We've just learned it. What is that initial blood work? What's the initial blood work, please? What is the initial blood work? Beautiful. Parathyroid hormone level. After the initial blood work is requested above, which other lab investigations will you request? Remember that when we were solving the first question, a lot of people were saying magnesium, phosphorus, vitamin D. But then we learned that the most important initial blood work to do in a patient with hypocalcemia is parathyroid hormone levels. So this question is basically asking you that after you've done the parathyroid hormone levels, what other investigations will you request? What other lab investigations will you request? So I've seen people typing in, no, doctor, on Facebook, the parathyroid hormone level has already been done because the question says that after the initial blood work, so what else are you going to do? What you're going to do is you're going to check your serum magnesium level, because remember that the objective said you must learn the relation between serum magnesium level and, and calcium levels. Serum creatinine. Why? Because there's a relationship between hypocalcemia and chronic kidney disease. Phosphate level. Why? Because we said that hypocalcemia in the context of hyperphosphatemia, you are thinking about chronic kidney disease. Then we're also going to check the vitamin D metabolites. Now, there are two vitamin D metabolites. We have 25 hydroxy vitamin D, and we also have 125 hydroxy vitamin D. Two vitamin D metabolites. Please mute yourselves. Okay, we have two vitamin D metabolites, and you will, as we learn, you will see the context in which you should think about this or that. But parathyroid hormone level has been requested. What other investigations will you request in a patient with hypocalcemia? Number 1, serum magnesium. Number 2, serum creatinine. Number 3, serum phosphorus. Number 4, the two metabolites of vitamin D. Number 5, alkaline phosphatase. Number 6, amylase. Why? Because we learned that acute pancreatitis can also cause an elevation in acute pancreatitis can also cause hypocalcemia. We learned that. That's why we are requesting amylase level. And then urine calcium excretion and urine magnesium excretion. So these are the further investigations you will do after you've done your initial investigation for a patient with hypocalcemia. And I've given you reasons. We've learned that there's a relation between hypocalcemia and hypomagnesemia. We've learned that there's a relation between hypocalcemia and chronic kidney disease. We've learned that there's a relation between hypocalcemia and phosphorus levels. We are going to learn that there's a relation between hypocalcemia and vitamin D levels. And there are two metabolites of vitamin D. Yes, Dr. Ola, please, your question.
Yeah, thank you, Dr. Obroni, for the presentation or for the teaching. First of all, is to just clarify, hypomagnesemia goes with hypocalcemia, right?
Yes.
Okay. All right. So my main question is about the acute pancreatitis. I don't know if you can help, probably the pathophysiology. How does acute pancreatitis result in
Let me go back.
hypocalcemia?
Let me go back. I don't know that I have not really gone into the deep pathophysiology of that, but then like it's there's lots of calcium from circulation in a patient with hypocalcemia at times when they are in that acute state. That's what presents, but I don't know all the details about the nitty-gritties of that. I can look for it and then maybe let you know in class.
All right, thank you.
I can look for that. Sure.
Okay.
So let's do the math again. If you have a patient with hypocalcemia and that patient also presents with high parathyroid hormone levels, what's your next step? Can somebody help us? Hypocalcemia in a patient with high parathyroid hormone level, not high phosphorus, high parathyroid hormone level. What's your next step? The next best step will be to check the phosphorus levels. Okay. So please let's break it down. If you have a patient, we are learning that if the patient presents with hypocalcemia, the next best investigation is parathyroid hormone levels. Now, if you have a patient with hypocalcemia and high parathyroid hormone levels, what's your next step? The next step is for you to check the phosphorus levels, because we said that there's a relation between hyperphosphatemia and hypocalcemia, and that's in the context of chronic kidney disease. Okay, so that is something you want to look at. So I want us to go through this quickly. If you have a patient with low calcium and the parathyroid hormone level is high and phosphorus level is normal, what are you thinking about? Because I can easily give you, a case like that. But instead of taking you through all the various long form content, I'm just putting it short. Low calcium, high parathyroid, normal phosphorus. What is my differential? Low calcium, high parathyroid hormone levels, low phosphorus. What's my differential? And the answer is low calcium, high parathyroid hormone level, normal phosphorus. I'm thinking about conditions like pseudo hypoparathyroidism, acute pancreatitis, drugs like calcitonin and loop diuretics. Okay. Now, if the patient presents with low calcium, high parathyroid hormone levels, and phosphorus levels are low, then I'm going to think about, is this related to vitamin D? And other conditions like cystic fibrosis, phenytoin, rickets. But remember that hypocalcemia can present in patients with pancreatitis. Also remember that hypocalcemia can present in patients with vitamin D deficiency. These are the two things I want you to pay attention to. Pancreatitis, vitamin D deficiency. Now, if you have a patient with hypocalcemia and parathyroid hormone level is low, because we learned that if the calcium level is low, usually I'm expecting parathyroid hormone levels to be high in a normal person. But if calcium levels are low, parathyroid hormone levels are low, we said that then we are thinking about hypoparathyroidism, right? What investigation am I going to do? if I have a patient with low calcium, low parathyroid hormone level, what investigation will I do? I've seen some people typing in some answers. Some are saying mileage and all that. I'm going to check for magnesium. I'm also going to check for liver function test. Because remember that we said that some of the further investigations you will do will be ALP, will also be magnesium levels. Okay. So now, if I have a patient with hypocalcemia, low or normal parathyroid hormone level, and low magnesium, what differential am I thinking about? And if I have a patient with hypocalcemia, low parathyroid hormone level, and abnormal liver function test, what differential am I thinking about? So I built it up from all those equations to this. Hypocalcemia, low parathyroid hormone level, low magnesium, low. What am I thinking about? And then hypocalcemia, low parathyroid hormone level, abnormal liver function test. What am I also thinking about? Two things. Number one, if I have a patient with hypocalcemia, remember that we learned it in the Dr. Violet, what's your question? Okay, I'll go on. If I have a patient with hypocalcemia, low parathyroid hormone levels, and then low magnesium levels, I'm going to think about drugs, as we said, or a patient who is an alcoholic. And then remember that we also said that iron overload can cause low calcium levels. If I have a patient with hypocalcemia, low parathyroid hormone levels, and abnormal liver function test, I'm going to think about iron overload. Why? Hemochromatosis. Because hemochromatosis, there can be deposition of iron in the liver. So these are hard facts. And I know that, you may be a bit confused. All I need you to do is just write these points down. In my board exam, if I have a patient with low calcium, low parathyroid hormone level, abnormal liver function test, the diagnosis I'm going to think about is iron overload, secondary to hemochromatosis. If I have a patient, hypocalcemia, low parathyroid hormone level, low magnesium, I'm going to think about drugs like phenytoin and a patient who is an alcoholic. If I have a patient with hypocalcemia, low parathyroid hormone level, remember that we said that it could be that the parathyroid gland has been removed. Maybe when they were doing a thyroid surgery, then the surgeon accidentally removed the parathyroid gland as well. Or it could also be that the patient was exposed to ionized, the patient was exposed to some form of ablation in the neck, and because of that, there's a problem. Okay? And then it could also be that I corrected hyperparathyroidism and I did a surgery. So maybe the patient's parathyroid gland was producing so much and I did the surgery. Now I've destroyed the whole parathyroid gland. And so even though the patient is hypocalcemic, the patient is not able to stimulate the parathyroid gland to produce parathyroid hormones. And that is why that patient has low calcium, low parathyroid hormone levels. And then this particular one about primary hypoparathyroidism is basically, reviewing all the things we've said, that HIV can cause hypoparathyroidism, idiopathic causes, autoimmune, infiltrative diseases like iron overload can also cause this. So if you have a patient who presents with hypocalcemia, I want us to recap everything. There are questions you want to ask yourself in an exam situation. Number one, is there hypocalcemia? Number two, what is the level of the parathyroid hormone? Because we said that the parathyroid hormone is the most important investigation you have to do if you have a patient with hypocalcemia. Then number three, we said, is the parathyroid hormone level high? And is the phosphorus level low or normal? And then last but not the least, magnesium level. So if you have a patient with hypocalcemia, three investigations you want to do: parathyroid hormone levels, phosphorus levels, and magnesium levels. These three things: parathyroid hormone levels, phosphorus levels, and magnesium levels. But remember that parathyroid hormone levels should come first. Doctors, can I proceed? Parathyroid hormone levels should always come first. Okay, good. Now, the next question is saying, construct an effective initial management plan, including administering IV calcium if the patient has symptomatic hypocalcemia. So, the objective is even giving you an answer already. He says if the patient is symptomatic for hypocalcemia, your management should be administering IV calcium. And you also have to determine whether the patient needs specialized care or not. So let's go to this question. You are assessing a 65-year-old female in the emergency room. She presents with perioral numbness. Her serum calcium level is 1.9. How will you manage the patient? You are assessing a 65-year-old female in the emergency room. She presents with perioral numbness. I have a question. In this patient, is the patient symptomatic or not symptomatic?
Symptomatic.
Symptomatic. Why? Because the patient has developed perioral numbness.
Perioral numbness.
So perioral numbness in the context of hypocalcemia, what did the objective tell us to do? We should give IV what? Calcium. So the question is, how will you manage this patient? One of the things is the patient is symptomatic. First and foremost, I want to check the airway, breathing, and circulation. Why? Because we said that hypocalcemia can do what to the larynx? When we're learning, what did we say? What can it do to the larynx? It can cause spasm. Exactly. It can cause difficulty breathing, right? But then, if there's no spasming of the larynx, but the patient just has perioral numbness, then the objective also told us that if the patient is symptomatic, we've got to give IV calcium gluconate. Then after your IV calcium gluconate, you've got to give other things like vitamin D replacement. Because maybe after you've given your IV calcium gluconate, you may want to discharge the patient home on oral calcium. And if you are discharging the patient home on oral calcium, then you want to give vitamin D replacement as well, so that it can help with the absorption of oral calcium. And another thing you also want to give is if there is hypomagnesemia, then you want to give IV magnesium. So remember that hypomagnesemia goes with hypocalcemia. And if there's hypomagnesemia, then you want to give IV magnesium as well. Because if a patient has hypocalcemia and is symptomatic, and you are just giving IV calcium, and you also check the magnesium and the patient is hypomagnesic, and you don't correct that, then there'll be a problem with the absorption of calcium. So let's recap again. In a patient with low calcium level and the patient is symptomatic, the first thing I want to do is to check the ABC because of laryngospasm. After I check the ABC, the next medication I need to give, according to the medical council's objective, is that I need to give IV calcium. Now, when I'm discharging the patient home and I'm giving the patient oral calcium, I also need to make sure that I am covering the patient with vitamin D supplementation, because with oral calcium, the patient needs vitamin D to help absorb it. Another thing I need to also know is that hypomagnesemia goes with hypocalcemia. So if I have a patient who has hypomagnesemia plus hypocalcemia, and I'm correcting the calcium level, I need to also make sure that I correct the magnesium level as well. If I don't do that, there'll be a problem with the absorption of the calcium. Doctors, this is hypocalcemia made ridiculously simple. Now I have a question. Let's do some rapid fire. And you can unmute yourself, but please let's one person at a time. Number one, if I have a patient with hypocalcemia, what's the next best investigation? Parathyroid hormone level. Okay. If I have a patient with hypocalcemia and parathyroid hormone levels are also low, what's my differential diagnosis? Or what's my top diagnosis?
Hypoparathyroidism.
Hypoparathyroidism.
Hypoparathyroidism. Beautiful. Now, if I have a patient with hypocalcemia, with hyperphosphatemia, what diagnosis am I thinking about?
Kidney
Chronic
disease.
kidney disease.
What are some medications which can cause hypocalcemia?
Phenytoin.
Phenytoin, niacinamide, calcitonin.
Loop diuretics.
Exactly.
Bisphosphonate.
If I have a patient who is symptomatic for hypocalcemia, what's the first thing I will check for?
You want to check the airway.
ABC.
After that, what will I give?
Action
High
gluconate.
gluconate.
If the patient has
IV.
hypomagnesemia alongside the hypocalcemia, what will I give in addition?
IV magnesium.
Magnesium.
High magnesium.
Patient is being discharged home on oral calcium.
Vitamin D replacement.
Vitamin D.
Doctors, please, has it become very simple for you now? Okay. If the patient has mild, this is not hypercalcemia, sorry. Let me correct it even before we move on. This is not hypercalcemia. It's mild hypo. Sorry about that. If the patient has mild hypocalcemia, that's one. Mild hypocalcemia basically means the patient is not symptomatic. Okay, now, since we are talking about symptomatic, what are some of the features that I will know that this patient is symptomatic? We learned it. What are some of them?
Hyperreflexia.
Hyperreflexia.
Truvectory.
Tetany.
Hyperreflexia.
Sign.
Hyperreflexia.
Sure, Chivostek sign.
Trousseau sign.
Beautiful. What about the chest, the heart? There can be abnormal, right?
American.
Okay, good.